Okay, temporal arteritis, also known as, aka, giant cell arteritis. The temporal arteritis is pretty much what it says, okay? You have arteries, and they're inflamed. And which arteries are inflamed? The ones in the temple arteries, okay? The temporal arteries. And that's all it really says, inflammation of temporal arteries. Well, why out of all of your arteries, why does this one seem to make a difference? Well, we'll get to that in a second, but what's the cause of it? Most of the time, really don't know, okay? Again, it's, what do we call that? Idiopathic, right? Because we are idiots. We don't know. So, most of the time, we really don't know. We think that it's an immune response, okay? That's like the leading theory out there, is that you have an immune response that affects these arteries and causes them to swell up. All right, so what's going on? All right, get ready for some awesome artwork again. This is, wow, that's really bad. That's a really big chin. Okay, my eye and my nose and a really, really big chin. Okay, that's really bad. That's like really ugly, dude. Hey, what the heck? I don't know what happened there. Okay. Anyway, so either way, even with my very ugly dude, you know, we can agree your temples are somewhere around here, and you got an arteries that go through there. Okay, so this is my little temporal arteries. The temporal arteries, as they get inflamed, is a problem. And keep in mind this anatomy, such as it is, that I'll get back to in a second here. All right, let's get back to that in a second. Well, let's look at signs and symptoms, okay? These aren't signs and symptoms, are they? No, not really. This is more of a risk factor that 50 years or older. You can certainly get temporal arteritis when you're younger, but that's a risk factor thing, not a sign and symptom. Okay, throbbing pain. Okay, if you ever had like a temporal headache or something where it hurts in that region, sure. Okay, same thing. You can rub your temples. You can feel that temporal artery there. Okay, visual changes. All right. Well, if you think about it, you know, you start back here in the occipital region of your head, and that optic nerve is going all the way from the back, all the way through, and eventually to your eyes, right? Well, that temporal artery is right there in the middle of all that, and if it starts swelling up, it can press on that optic nerve that's trying to travel through there. Alrighty. Now, not only is the visual changes a possibility with temporal arteritis, but if you look down here, it can actually lead to irreversible vision loss, as in your vision is not coming back if you have temporal arteritis long enough pressing on that optic nerve. Then you can literally kill that optic nerve. Okay? So let's get back to there in order. Throbbing pain, visual changes, weakness. Sorry. I think what they're meaning is weakness in the face, weakness in the jaw, that sort of thing, because it's cutting off the flow of blood to my massive jaw down here, right? And that's going to hurt and be fatigued. And if you don't have enough blood flow, then you know it's going to hurt. Loss of appetite. Not really sure about that. It may be due because of the mechanics of that, or it may actually be pressing somewhere on that hypothalamus in there. I really don't know exactly what the loss of appetite is all about. Appetite is pretty subjective kind of thing anyway, and it doesn't always follow the rules it's supposed to. All right, often it makes sense, often mistaken for a tension headache. Okay, that makes sense because it's right there and you know, in your temples. And like I said already, it can lead to irreversible vision loss. Testing, how do we test that? Well, what we got here is because it is inflamed, any itis, again, this is for all of the itises, by the way, you're going to have increased C-reactive protein. Okay, remember that one, the C-reactive protein that was one of those. It's not very specific for inflammation somewhere in the body. Okay, that's of course going to be increased for any inflammation, any itis will do that. Okay, biopsy for definitive diagnosis. Well, there is a video link right here, and if you look at that, they go through, not that you can click on it on this video, but you have the PowerPoints on Angel, so check that out. The video link will go through a temporal arteritis surgery and cut it open and tell you basically what they do is, well, I'm going to draw my temporal artery like so, and if that thing is all swollen up and it's messed up, and it's only in, for example, say this portion of it, they will literally just cut that thing out and tie it all together so that you can use it. Well, you just cut off a big artery. Keep in mind that, you know, arteries, they do have, you know, branches and things like that, so it'll find its way around there. So it's not like you're, as long as you're not chopping off major arteries and that sort of thing, most of the time you can go without an artery or a vein or something like that and get away with it. Okay. Treatment, however, you do want to try first before you go in there and start chopping things to pieces, but you're talking about a long time. Corticosteroids, okay, these are going to bring down inflammation, right? That's what they do. They bring down inflammation, and that's my inflammation. And that's what they're supposed to do, but this takes a very long time if it works. Alrighty, and that's fine. It's better than having somebody go in your head and start chopping around in there and cutting things up. By the way, corticosteroids will also work for the inflammation of the meninges or the brain too, right? It's a corticosteroid. That's what they do. They decrease swelling. Okay, this is my temporal arteritis. This is the one I was trying to draw over here, and you can see where, you know, kind of the different branches of it. This little branch coming off right up here is this little guy right there. Alrighty, and this is a little drawing. So it's all the same thing, just kind of showing you where that temporal artery goes, a superficial temporal artery. Okay, the next little topic here is the intracranial hematomas. Again, we're talking about severe headache that you're going to get. I already went over the dura mater and the pia mater, most in, arachnoid matter in between, and dura mater on the outside. Okay, so those meninges, well, we have different kinds. This one is below the dura mater, and it's kind of, actually I should have drawn that right here because now that's the arachnoid matter. It got pushed. So you got in between the dura mater and the arachnoid matter, which is here, and then the pia mater just kind of shoved right into it, is a subdural, below the dural level, and it's hematoma because it's blood in that area. So now you got blood under the dural layer, under the dura mater, okay, for this example. Okay, so we have different kinds of hematomas, and we do have the arachnoid space that you could have a subarachnoid hemorrhage also. But for now, we're just talking about hematomas or bleeding in the brain. Okay, like I said, there's a couple different kinds here. Let's start with the epidural, as in the one on the outside of the dura mater. So again, if it's the whole, this is the skull, this is the brain, and you got your dura, arachnoid, and pia maters, then you can have one up here too, right? The last one we saw was subdural down here, dura, and this one's epidural. So you get an epidural hematoma, or extradural they call it, outside the dura mater, and you bleed into that space. Okay, that one is pretty fast. Okay, you bleed there, it's a pretty fast bleed, usually some kind of trauma or something cracked open your skull and started bleeding in here. All right, there's a lot of superficial blood vessels out here on the epidural space, so you do see a lot of bleeding in there, so it kind of goes fast. The subdural, however, is a little less predictable. So I'm going to make this dura mater a little bit thicker right here. Okay? Not that it's inflamed or anything, I'm just making it thicker to show you the subdural space right here. Well, there are arteries and veins and sorts of blood vessels in the subdural space, and it can go either fast or it can go slow or somewhere in between there. So apparently right here is not where we're talking about it, but you actually have three different kinds that we kind of have to know. You got one that's acute or really fast, acute subdural hematoma, or a really long one that would be chronic, okay, subdural hematoma, and then you got one that's right in the middle, okay, and we'll get to that in a second. And that's just how fast it's bleeding. Of course, it's the same place. It's just the relationship is basically how much arterial or venous damage did you do, and how big is the hole, whether it bleeds really fast or it takes a long time to bleed out, or somewhere in the middle, right? Okay. Causes the head trauma. Anticoagulants. Okay, so maybe for whatever reason you were taking some warfarin or heparin or something like that, and you just basically can't coagulate the blood and you get some kind of head trauma. Well, of course that's going to increase your risk. You just made it so that you're, an effective hemophiliac, right? Age, always. That seems to be increased risk for everything. As you get older, then things don't work as well. Your arteries are already stiffer and tougher, and the brain doesn't bounce around as well as it should, that sort of thing. Okay. Congenital malformations, as in you were born with them. Okay, so you will have some kind of, occasionally you'll find like arterial venous things that aren't really matching up correctly, so that obviously would increase your risk. Again, these are kind of like does, right? If you have something already messed up, or you're old, or you're taking medicine, yeah, it can increase it if you get a head trauma or skull fracture for that matter. Aneurysm, again, it's kind of a duh. If you blow an aneurysm and you start bleeding into this space or any of these spaces, then duh, of course you're going to get a hematoma. That's pretty much what happens, right? Signs and symptoms. Headache, that's not new. That's kind of what this module is about. And nausea and vomiting, sure. Again, it's not listed on every single slide, but you can kind of throw nausea and vomiting in everything. Visual changes, if you are bleeding inside your brain, sure, you're causing pressure inside your brain. That could certainly cause visual changes. Again, I don't know that that's necessarily unique to a hematoma either, right? You're bleeding inside your brain. You're still putting pressure on the brain, whether that, for what reason that is, whether it's temporal arteritis putting pressure on a nerve or a brain, or whether that's, the meningitis or encephalitis or hematomas, whatever. You're putting pressure on the brain, you're going to get kind of the same things, the altered level of consciousness. Again, now we're talking about, you're not going to probably get hemiparesis from something like temporal arteritis, but we're talking about a hematoma, and as this blood comes in, it literally will take this, more blood, and it's filling that space up and pushing your brain in, so then you kind of get a brain that kind of has like a dent in it. All right, well, depending on where that is, that may actually paralyze you. Okay, on one side, whatever that side is. Okay, speech disorders, as we learned earlier, maybe it's pressing on your Broca's area, or maybe your Wernicke's area or something like that, and causing a speech disorder. Again, hopefully these make more sense than just trying to memorize them. You're pressing on your brain. Okay, think about it. Anything that can really happen when you put pressure on your brain is true for hematomas, and it's true for anything else like it's pressing on your brain. Okay, testing is usually the CT, look at it, see what's going on, and the MRI. Okay, so I don't know that there's anything necessarily new on here, but you can see where it's different in only that some of these things like anticoagulants and congenital malformations from like arterial venous problems that would increase your bleeding, over like meningitis, encephalitis, and temporal arteritis and that sort of thing that does increases your pressure inside your head. Okay, let's look at epidural hematoma here in a nice little drawing over here to the left. I'm kind of even afraid to draw on it because it looks so cool. But there you have it. You're bleeding in your epidural space. If you notice here, this is only skull right there. There's no membrane. First membrane you see right here is the dura mater. So that's your epidural above the dura. Hematoma bleeding in there. As I said before, it pushes the brain in. So as this brain is being pushed in, it's going to be causing major problems and, you know, transferring that pressure all through there, and certainly you could cause some problems there. Let's look at it here. It looks kind of the same, right? If you look in right here, you can see, you can see here where it's not supposed to. Your brain is not shaped like that normally, right? So you can see that bleeding in there. This is, you know, a little right there, and, you know, depending on what level you're taking this picture at, it may or may not be a bigger size. Okay. It's a little bit hard to see, but if you notice this line right here, you can see where that line right in here is kind of shifted over a little bit. The whole brain is kind of shifting, so it's putting pressure throughout the entire brain, not just, you know, in this part that it's pushing on. It's got to go somewhere. Okay, so it's causing issues everywhere. So it's a little bit hard to predict sometimes on these hematomas on how they're going to manifest as far as the physical signs and symptoms go. Okay. Epidural, again, it's the one right out there in the outermost part of the meninges, and, you know, normally that would be because of a skull fracture. You break that temporal bone, or you break the middle meningeal artery. You cut that and it bleeds into there. So nothing really significant or hard to comprehend, I hope, on that part. Okay, but the brain is usually not the problem. That's usually minimally damaged, if at all. The problem is when it starts pressing on the brain, then you start seeing all these nerve deficits and the headache, and, you know, then you start seeing the major problems. But the brain itself isn't damaged by the accident or the trauma or anything. It gets damaged as it gets pressure on it all the time. Okay? And now that I have drawings all over this thing, it's a little hard to see, but it was just showing you the different arteries. Okay. All right, subdural hematoma. We were talking about epidural on the last slide. Now we're going subdural. Again, what's really different? Nothing much. Now it's instead of in the dura. Oops. So now instead of it being in the dura right here, or above the dura, now it's below the dura. Okay, so not really much difference there, other than what side of it's on. So that's really all it's saying. Usually you're talking about laceration of veins, because there's a lot of veins in that dura mater and below it. And this is a kind where you have the three that I talked about, right? You have your acute, your subacute, and your chronic. Okay. Of course, we already said it causes increase in intracranial pressure and herniation, okay, as in the brain herniation. Or, again, what I was showing you before is, you know, if this is your normal brain inside the skull, obviously over-exaggerated, and you push something, it gets herniated, right? It kind of sinks in, it gets pushed in, so that's herniated. All right. So herniation may result. You look in the eyes, what might you see? Okay, think about it, and if you have like an optic nerve going through here, and these are eyeballs in the front of your head, looking that way, I hope, then you press on that optic nerve, yeah, well, actually they cross over, but what you would see is as that presses on there, you're going to maybe lose some of your vision in here, right? Well, you lose some of the nerve innervation, I guess, is probably more accurate, and your pupils in here could be like dilated and fixed because you're not really getting the optic nerve maintenance that you should be getting. Okay, so the effects, again, headache, confusion, that sort of thing, and depending on which one we're talking about, it says effects begin 48 hours post-trauma. Again, you may not notice the clinical effects depending on whether it's, you know, chronic, subacute, or acute. But acute is very fast. Subacute is probably more 48 hours-ish area to a week or so, and chronic is, you know, maybe weeks, many weeks to months, where you can actually see the major clinical manifestations. Okay. Epidural versus subdural hematoma, information from Mayo Clinic. The epidural hematoma, again, we already said that, also called extradural, usually an artery ruptures between the outer surface of the dura and the skull. We already got that. Blood leaks between the dura mater and the skull to form a mass that compresses the brain tissue. Nothing new there, right? Some people with this type of injury may remain conscious. Okay, good. But most become drowsy or comatose from the moment of trauma. Okay, so not only did they get whacked by something hard enough to rupture arteries in the epidural space, but now you're starting to see bleeding there, and it looks pretty fast as far as the manifestations, because again, epidural hematoma, we're talking an artery, not a vein here. These things rupture, they bleed pretty fast. Okay. Risk of dying from an epidural hematoma that affects an artery in your brain is substantial. Oh, I get it. It's substantial risk unless you get prompt treatment. Okay, so again, epidural hematomas, usually pretty bad bleeding, not a good thing. Okay, if you see this big old dura mater area, that white thing, this is epi, that's clearly above the dura mater, that big old blood clot right there. Alrighty. Again, subdural hematoma. These are our three kinds that I keep mentioning here. So you got acute, subacute, and chronic acute. It's the most serious because it's bleeding the most. That's why it's acute and life-threatening, right? It's generally caused by severe head injury. Signs and symptoms usually appear immediately. So this acute subdural hematoma looks a lot like that epidural, doesn't it? So the epidural and the acute subdural actually look a lot alike. They're both very serious. They're both life-threatening. They happen really fast. Okay? Pretty bad head trauma usually. Subacute, okay? Signs and symptoms, they take longer to appear, sometimes days or weeks after injury. What I like to say is, again, we're not going to make this too tough on you. We want you to get the concept here. What is subacute versus acute versus chronic, right? So if this is, I'm going to say, you know, like now, you know, maybe now to 3 to 5 hours, okay, that's where that's really manifesting, right after the trauma. This subacute, you know, we're talking, sorry, now that I put that there, that doesn't work. This subacute here, days or weeks, so maybe we're going to say, you know, 3 days or, you know, 8 days or something like that. Okay, when we're talking about chronic, okay, you obviously you have a less severe head injury, you have less bleeding from that, and it's a lot slower. That's why it's taking so long. And if you're talking potentially take weeks to appear, all right, maybe, you know, we're talking, I'm going to have to say something like, you know, more than somewhere around a week, and definitely not now. So maybe we'll say something like 3 weeks, or, you know, a month later, okay? So that's how you really tell if it's, you know, chronic, subacute, or acute. There's, I'm sure somewhere somebody has it written down what the official times are, because there's always an official something or other, but to simplify it, we're just going to make it where it's either a long-term kind of thing, like 3 weeks to a month, or subacute, like it's, you know, basically a few days to a weekish around that area, and then absolutely right now. Okay, so that should be fairly straightforward. One thing you do have to keep in mind, though, is all 3 types require medical attention as soon as signs and symptoms are apparent. Well, okay, that makes sense, because by the time these signs and symptoms kick in, whatever damage is happening is happening. So, you know, if this is, you know, the normal brain and it's getting pushed in like this, you're going to see the signs and symptoms when that starts pushing in. If it takes a month to push that in, then it's still just as serious at that point, because now you're still in the major danger of dying here and killing brain tissue. Okay? If it happened in 3 hours, obviously that's, you know, easier to diagnose because you see it immediately. And this is, again, kind of a duh thing here, right? Any kind of bleeding problem. If you're using aspirin or anticoagulants daily, or alcohol abuse, or you're very old, those are risk factors for any kind of bleeding problems that will make it harder to recover from. Okay. We are at 25 minutes on this part, and I'm kind of going to have to, hang on, let me see, let me look here. Yeah, dang it. Yeah, I'm going to go ahead and finish this hematoma treatment, I guess. We'll get through that. It's pretty fast here, right? Hematoma treatment, how do you treat it? Well, decrease the intracranial pressure, whether that's, you know, corticosteroids to do that and to decrease the pressure, and by the way, it gets rid of edema, or mannitol, which is a very, very, very effective and strong antidiuretic that'll decrease that pressure in there very fast. And then sometimes you might have to go with barbiturates to induce a coma and put them in a coma to keep that brain activity down until that swelling comes down. By the way, the barbiturates is how everybody always says it. Technically, I believe it's actually called barbiturates, and I have heard people pronounce it that way. Usually they're, you know, very high and mighty Harvard doctors, but I think that probably is the correct way, but everybody always says barbiturates. Anyway, side note. And surgery, of course, is pretty much mandatory in all of these hematomas. You got to stop that bleeding, right? Okay, now let's end that one here, and we'll do a next video for the next part that is going to start with papilledema.